My name is Gilles Salles from Memorial Sloan Kettering Cancer Center in New York. I'm very happy to be with you today discussing recent advances in diffuse large B-cell lymphoma. There was very rich years recently with the approval of CAR-T, with the development of bispecific, and with the approval of several new agents in the relapse setting. And what we are going to try to do today is review some of these advances together. So maybe the first study that I would like to discuss with you is the POLARIX study. As you know, this study was a randomized phase 3 study in the first-line setting of patients with diffuse large B-cell lymphoma with an international prognostic index score of 2 to 5. And this was a simple randomization of R-CHOP, 6 cycles, versus R-CHP POLA. And the design was really a double-blind placebo-controlled trial to allow to precisely evaluate the toxicity of these different regimens. There were 2 cycles of rituximab added at the end of this chemo, which value may be a challenge, but that was the general figure of the study. The results have been now published and presented, and the primary endpoint was primary progression-free survival, and it was reached with an improvement of PFS of polar R-CHP versus R-CHOP. The hazard ratio is 0.73, which means that basically there is a 27% reduction in the risk of disease progression, relapse of death. In other words, when there were 4 patients that were relapsing with R-CHOP, we probably diminished that to 3. So I think it's an interesting result for our patient, knowing that we aim to cure this patient. However, there was no difference in best overall response, especially CR rates between the 2 arms. The disease-free survival was improved, but as you know, there is no overall survival at this point between the 2 arms. There are maybe different explanations for that. One of them is the still rather short follow-up, which was a median of 2.5 years at this time of the publication. The second one is the efficacy of subsequent treatment received by patient. And we do know that patients that relapsed after R-CHOP were candidate more frequently to effective systemic therapies, to stem cell transplant, to CAR-T, and probably even more down the line with second relapse and so on. Whether this will stand on the long term or not, we still don't know. If we look at the exploratory pattern of patients that responded or did not or benefited from this regimen versus those who didn't have a benefit, I think there are a couple of interesting indications to be taken still with a grain of salt, because these are exploratory analysis, but that may help us to understand which are the patients that may benefit from this regimen. As you can see from this forest plot on the top, patient older than 60 seems to truly benefit for polar R-CHP, as well as 2 lines below, patient with an IPI 3 to 5. Maybe it's not great benefit for patient with a very bulky disease. But again, going down, interestingly, the patient with the so-called activated B-cell subtype or non-GCB, DLBCL, are those that really appear to benefit, as well as the so-called double expressors, those that have an expression of MYC of BCL2. So, it seems like the patients that are older with more adverse features in the International Prognostic Index, or more adverse feature in terms of biology, such as ABC subtype or double expressors, may be those that have more benefit from polar R-CHP.
So I'm kind of curious, particularly about the cell of origin subtype. We have done surveys of investigators suggesting that there are quite a few of them who sort of take it to heart and would like to use polatuzumab for ABC and are not very enthusiastic about germinal center. Do you feel the same way from a clinical point of view at this point? I mean, of course, scientifically, you brought up the fact that, the statistical issues, but from a clinical point of view, do you feel it's something that warrants clinical application?
Well, to tell you the truth, what I did in my practice is I have seen a few patients that were not eligible for open clinical trials here at Memorial, but were either 65 or more, or had adverse features, or were ABCs. And I have tried to obtain polatuzumab for this patient, and actually always succeeded so far. So I think when we have patients with adverse features, we do know that R-CHOP will not provide the best results. And I think it's wise to try to optimize the outcome of this patient. When the FDA will make a decision, probably somewhere late spring, we will see what the decision will be. And I will say, subgroups have always to be taken with a grain of salt of caution. But I think that clearly there are here some patients that are more difficult to treat, patients who may not be always eligible for CAR T-cell in the relapse setting, and I believe we should really in priority try to approach this patient with polar R-CHP if feasible.
So, how about if I say, would there be any downside to just giving Pola to everybody other than the financial?
Well, I don't think there is a downside, and that brings me to my next slide, which is basically the adverse event slide in this trial. And as you can see here, what is quite apparent from this tornado plot is that there were no major differences in the very common adverse events that were observed between the two arms of the study. What is different is the rate of neutropenia and febrile neutropenia, which is higher in polar R-CHP, but we are still dealing with numbers that are quite acceptable, I will say. We are in the 8% with R-CHOP, 13% with polar R-CHP. So this can be a concern, but I will say we are all used to monitor and manage this patient for febrile neutropenia, DLBCL patients. This is a common thing. What was reassuring, and again, this was a double-blind study, was the fact that there was no increase of peripheral neuropathy with polar R-CHP as compared to R-CHOP. There were no differences in the number of patients that had diminution of the putative neurotoxic drug or had to discontinue this drug during treatment. There may be a little bit more diarrhea with polar R-CHOP, but a little bit less constipation. And during the ASH meeting, Jonathan Friedberg presented a poster with the patient-reported outcomes showing that overall there were really no significant difference between the two arms. So besides the cost, to come back to your question, I think that really there is no downside to use polar R-CHP for everybody that were the patients in the study, which means patients with an IPI 225.
I think everybody was looking for the peripheral neuropathy data. I'm curious what your experience is with Pola in terms of peripheral neuropathy. I imagine you've given it to quite a few people with bendamustine. Can you give me more of a qualitative feel? Let's say compared to brentuximab.
I think, we have the same toxin here, and we have the same concern, I will say. So what we have learned from the early data with polatuzumab of the phase 1-2 data, and when it was developed in both aggressive and indolent lymphoma, and with continuous administration until progression, is that when patients go over 6, 8, or even more cycles, then we start to have peripheral neuropathy. And some of this peripheral neuropathy can be severe, can involve not only sensitive but also motor neuropathy, and some may not be reversible. So as long as we are in the 6 cycles, these data here, which are, again, randomized, double-blind, are very reassuring compared to vincristine. And when we use BR Pola in the relapse setting, I think we usually have no more than 6 cycles. And I haven't encountered patients with severe neuropathy. And, it's essentially grade 1-2. It's reversible in many instances. And it's not a major handicap for this patient who are, however, in the relapse setting. But again, this data are reassuring. We just basically have to think about it when we see patients with pre-existing neuropathy or pre-existing neurological disorders.
Okay, please continue.
So I just wanted to bring to your attention the result of POLARIX that were updated at ASH 2022 during a session where data presented by Dr. Alex Herrera regarding the cell-free DNA in this trial. I will not comment on the cell-free DNA. This will take us longer, but it brings us to the updated PFS result with now follow-up that exceeds 3 years. And as you can see, the difference that was seen in the early publication is maintained. At 3 years, there is a difference in PFS of 7.7%, same range of hazard ratio, 0.76, still statistically significant. On the downside, still no difference in overall survival. But I will say again, we have the indication here that probably we may avoid 1 out of 4 relapses. And I think the fact that with an additional year of follow-up, these data are consolidated is encouraging. We have to remember that, for instance, with BV-AVD in patients with advanced Hodgkin lymphoma, it took up to 5 years to see an overall survival difference. So let's continue to wait, continue to watch, and let's see what the health authority in the US will say. We'll move now to a couple of updates regarding the management of patients with relapsed or refractory DLBCL. And the first one is some updates that were published regarding polatuzumab vedotin in combination with BR in patients with relapsed refractory. I think you are all aware of these results. This was a randomized phase 2 study comparing BR only versus BR plus Pola, and there was a significant improvement of complete response rate, 40%, in the experimental arm in terms of PFS. This is a side on the curves on the left of the slide, and in terms of overall survival. What was interesting and what was presented and published recently was an extension cohort of this study where another 100 patients with relapsed refractory DLBCL were treated with Pola-BR. And what you have here on the slide are on the left the result of the randomized study with the BR arm down and the Pola-BR on the top, and on the right the extension cohort. As you can see, there is a diminution in the median PFS, which was 9.2 months in the randomized study for the Pola-BR arm, and it's only of 6.6 months in the extension cohort. I will say this is probably what you will expect when you extend the number of patients treated and recruit more patients in this phase 2 study. But I think 6.6 is still encouraging and may do well better than BR or even R-GEMOX. So I think it's still encouraging result, and the CR rate is maintained in this result. And, it's probably more severe patients that were included in this extension cohort that's in the publication. In addition, the median overall survival is similar, more than 1 year. And I think this comforts the use of Pola-BR as one of the regimens we use currently in relapse setting in different ways. The second study that I would like to mention, and that was also an approval, was the tafasitamab lenalidomide study. As you remember, this is an antibody directed against CD19 combined with lenalidomide, showing in the phase 2 study called L-MIND, published 2 years ago, an overall response rate of 60% with a 40% CR rate. What was interesting, and that's the second publication from last year, was the duration of response for those patients that achieve a CR. As you can see on the top curve, the patient responding, which is a yellow curve, had very prolonged response, especially those who were in CR. That's the top curve, with 80% of them being still alive without progression at 3 years. And we have obviously the same features for progression-free survival. So this obviously launched some interest in the combination of tafalen in the relapsed refractory setting of diffuse large B-cell lymphoma. It should, however, be noted that in this study, patients with truly refractory disease were clearly underrepresented, and that this result may essentially be true for patients with more relapsed disease several months after failing primary therapy or second-line therapy rather than primary refractory disease. There were some indirect comparisons that were carried on by us and my colleague Greg Novakovsky, comparing tafalen, the L-MIND regimen, versus other systemic therapy, versus BR, or versus R-GEMOX. And both in terms of overall response rate, CR rate, and PFS, we published that there was an advantage, so it may be better than the old combination. And more recently, we have some data suggesting some interest of tafalen compared to pola-BR or rituximab lenalidomide, and even some results that are quite challenging comparing to CAR T-cell. However, this has also to be taken with a grain of salt. These are clearly not randomized studies. There are very low number of patients used in this indirect comparison, and it may not represent the whole data set. But this represents clearly an interesting regimen. During the ASH meeting, a large consortium of UN centers presented some real-life data that were, I will say, showing results which were below the result of the phase 2 data, as we may expect, but there was clearly an overrepresentation of refractory patients, and only 10 or 15% of the patients in this real-life data cohort were similar to the one in the study. So an interesting regimen, clearly some data that confirm, but probably better used for patients who relapse several months after having been exposed to a prior therapy. The second drug that has been approved in recent years is the antibody again against CD19, but here an antibody which is a drug conjugate with another toxin, PBD. And as you can see on this slide, this was the early data of the phase 2 study, showing that there were about 40% of the patient responding to this antibody as a single agent, and about half of these responders were in CR, and these were true probably more for non-bulky disease and for patients treated at the right dose. But as you can see, an overall response rate of almost 42%. So these data were consolidated and published last year by Paolo Caimi in Lancet Oncology. This is the so-called LOTIS-2 study. And as you can see, there were 145 patients. The overall response rate is 48%, with half of these patients reaching a CR. This is true for DLBCL non-otherwise specified. There was a question for high-grade B-cell lymphoma, which we can discuss later. And there were very few patients with primary B-cell maybe not reaching the same result. The median PFS was about 5 months. You may say, well, 5 months, that's not fantastic. But again, these are patients failing at least 2 lines of therapy. And this is not very different from the median PFS of the early phase 2 of CAR T-cell in the third line of therapy. What was important again here was the median duration of response, which was about 10 months, as you can see. And on the upper curve of the lower panel, you can see that for those patients that have reached a CR, there were some that really benefited for a long-term response. Well, these drugs is manageable, and there was a paper recently regarding the use of lonca in patients with double or triple hit diffuse large B-cell lymphoma, the so-called high-grade large B-cell. As you can see, the CR rate was 34%. The time to CR was, very quick. I mean, patient responded in 1 month and a half. And as you can see from the swimming plot on the bottom, a few patients had very prolonged response. So for, again, a very difficult to treat population in the third line setting, some patients may benefit from this new agent. Regarding the profile of toxicity of lonca, which is administered IV every 3 weeks, there are patients that present adverse events. These are frequent. Some of them have only biological features, such as increase of gamma-glutamyl transferase and alkaline phosphatase. Some are more clinically relevant. About 1 out of 5 patients present with peripheral edema, but this is low grade and can be easily managed with a little bit of diuretics. If we look at the grade 3 or more treatment emergent adverse event, they are essentially hematologic. 1 out of 4 patients present with neutropenia, but very few febrile neutropenia, some thrombocytopenia. And I will say it's a drug that is manageable in this setting, as we will see in one of the clinical cases. Finally, the last drug that has been approved now some years, 2 years ago, was the first inhibitor of target, which is called XPO1, which is a protein involved in the inner cell nuclear export, protein transport outside of the nucleus or within the nucleus. So this drug is called selinexor. You probably know it by its use in patients with multiple myeloma. The result of the phase 2 studies that were published now 2 years ago showed an overall response rate of about 30%, exactly 28%, not very different from a patient with GCB or non-GCB. But the complete response rate remains relatively low, like as you can see, 12 to 14% in some patients. Since this early publication, and again, the median PFS was 2.6 months, so something not dramatically effective. The toxicity profile we know was hematologic and should be managed with lowering the dose of the drug, but also some fatigue, hyponatremia, nausea, and other GI defect. And I think if you want to prescribe this drug, you have really to accompany the patient with close monitoring in terms of dose reduction, in terms of growth factors. And you may want to use, largely and liberally anti-nausea agents, eventually antidepressing agents such as olanzapine, and monitor them closely. There have been 2 recent reports regarding this drug. One was the analysis of subgroup in these phase 2 studies that I just discussed. And as you can see, there were really no particular subgroups that benefited or did not benefited from this drug. Response as seen across all the different categories of DLBCL. And overall survival was a little bit longer for patients that were younger themselves, have higher lymphocyte count or lower LDH, but these are in general a more favorable patient here. The Princess Margaret Center, which was one of the centers where the study was conducted, actually presented about 22 patients. And as you can see, they reproduced the result of the trial with an overall response rate of 32%, 2 CR, 5 PRs. And, you can see from the curve below that some patients had a benefit of this drug that was quite prolonged, although it's a minority of patients. So I think 2022 was another revolution in the field of diffuse large B-cell lymphoma with the presentation and publication of the 3 trials assessing the value of CAR T-cell against CD19 against standard of care, which was represented, as you know, by salvage chemotherapy plus auto transplant. And the common feature of this trial is that they were targeting the poor risk patients, the patients that are either refractory to R-CHOP or responding but relapsing within 1 year after the last cycle of R-CHOP. So we are really focusing on this time where patients had received primary therapy but have failed primary therapy. So the 3 trials were done with the 3 products that were available, like Cicaptagen, Silolocel, Axicel, Tisagen, Leclecel, Tisacel, or Lysocel. I think we have all heard the result of this trial, and the curves have been published. The ZUMA-7, which is a trial with Axicel, was positive with, as you can see, a hazard ratio for event-free survival of 0.4 and a clear benefit for those patients receiving CAR T-cell. This is true also for Transform. Very similar hazard ratio, very similar shape of the curve, maybe a shorter follow-up, but we'll have a longer follow-up in another slide. So the surprise given these 2 results was the result of the first trial, the Belinda trial with Tisagen Leclecel showing clearly no differences. So there are a couple of explanations or hypotheses regarding the lack of benefit with Tisacel that we see with the other product. The design of the trial was slightly different in terms of number of cycles of chemotherapy allowed in the control arm, were a little bit slightly different in terms of all patients receiving bridging. And obviously, it still faces the delays in manufacturing of Tisacel, which meant that patients were infused much more later with the CAR T as compared to the other 2 trials. Is that the single explanation? Are there explanations inherent to the quality of the product itself? We don't know, but clearly this has challenged the use of Tisacel in real world also for third-line setting. But basically, the ZUMA-7 and Transform trial have really changed the way we manage patients with early relapse. And while they were obviously dedicated to patients that are transplant eligible, you may think that some patients may be able to receive CAR T even if you were not thinking they were extremely good candidate for autologous transplant. So this is just a slide presenting the update at ASH of the Transform study. Now that we have a little bit longer follow-up, you can see that the curve is exactly similar to the curve of ZUMA-7, and you can see the median follow-up in terms of PFS. Median follow-up is 1.5 years, and you see the benefit of lyso-cells compared to standard of care. This graph presents basically the result of these 3 trials. Again, you can see the differences in terms of the number of patients that proceeded to auto transplant. It's quite similar, in fact, in the 3 trials, ranging from 32 to 46 patients. And the vast majority of patients that were randomized to the CAR T arm received CAR T. There were some delay in the Belinda. There were differences in bridging. There was a crossover in Transform, probably to be interpreted with some caution regarding overall survival. And now with the median follow-up that has been extended, I will say the result of ZUMA-7 and Transform are very close in terms of efficacy. The CR rate, which is sometimes what patient ask, what my chance of achieving a complete response, was 65% in ZUMA-7, 66% in Transform. So very, very close by. What is different, and we know that, is that there is more toxicity associated with the use of axi-cel, and this is true in terms of CRS, grade 3 or more, or neurotoxicity. But those 2 drugs, those 2 CAR T products are very efficient, and when they become available, it's hard to make a choice one versus the other, and it takes time of accessibility. I think the other big news were the bispecific antibodies, although none of this drug has been approved in DLBCL yet. I have updated in these slides the result in diffuse large B-cell lymphoma from the year 2022. As you can see, with mosunetuzumab, the overall response rate is 33% and the CRF is 20%. You may have heard that this drug has just been approved a few days ago for patients with follicular lymphoma in the 3rd-line setting, and they are trying combining this drug with other agents in DLBCL. But at this time, the availability of this drug is restricted to patients with follicular lymphoma. Odronextumab is another drug that has been presented, and as you can see, a 40% overall response rate, 36% CR. Glofitamab and epcoritamab have a little bit more developed trials with more patients being treated in phase 2 for DLBCL. Overall response rate, as you can see, of 52% and 63% reciprocally, and CR rate strictly identical of 39%. So there are differences in those antibodies that I will try to briefly highlight. Glofitamab, as you know, is used intravenously, and the schema of the use of this drug in patients with relapsed refractory DLBCL was 12 cycles every 21 days. As you know, there is a step-up dosing with progressive increase of the dose to help managing the side effect. You can see here the duration of complete response, which has not been achieved, and a median PFS in the range of 5 months. And as you can see, at 12 months, vast majority of patients, 77% of those that achieve a complete response are still in complete response, and the 12 months PFS is 37%. So encouraging result. We obviously need more follow-up to see whether these drugs are competitive with the sustained response that we see with CAR T, but this is interesting. Again, talking about the management of side effect, there are cytokine release syndrome, which is prompting as a most concerning side effect, I will say. As you can see, about 2/3 of the patients had a CRS. The majority of them had only fever, but there are still patients that had hypotension, needed some oxygen for a few hours, and 4% of the patients have a grade 3 or 4 event, receiving eventually tocilizumab. Maybe with better learning curve, more liberal use of corticosteroid, of tocilizumab, we will help to manage this patient, but some patients still needed to be hospitalized, and that's not very practical, I will say, on the long term. But again, this occurs only during cycle 1, as you can see on the graph on the right, essentially during the first infusion and the second and the 3rd infusion. And after that, it almost disappears at cycle 3 and cycle 4. If we look to epcoritamab, and again, the result of both studies were recently published respectively in New England and JCO. This is a waterfall plot for epcoritamab. Overall response rate 63%, CR rate 39%. And interestingly enough, in patients with previous CAR T exposure, an overall response rate of 50% and CR rate of 34%. You can see these patients are marked with little asterisks here. The median time to respond is quick, 1.4 months, and the median time to achieve a CR is also less than 3 months. We have to learn about the duration of response. The median duration of response is 12 months, so quite similar. But I should point here one differences between the former drug is that this is continuous dosing until progression. So despite being subcutaneous administration, which obviously is more practical than IV, patients continue to come regularly and to be maintained. Whether it's important or not, it brings us back to the discussion we had with tafasitamab, but we have to follow this patient. Again, median PFS of 4.5 months, and majority of patients in CR were maintained in CR. So I think these are really two drugs that will probably be approved in 2023, or at least are thought to be examined by FDA now. In terms of safety for epcoritamab, just go back 1 second. Similar profile, similar AEs, essentially CRS event, maybe a little bit more predictable given the fact that it's subcutaneous infusion. As you can see, very few side effects during the first and the second subcutaneous injection, and the majority of them occur during the third. So you may be able to easily monitor the patients. I think we are looking for many combinations of these drugs. So based on these results, there are many combination trials of epcoritamab and glofitamab with different regimen in the relapse setting with R-GEMOX, for instance, and preliminary results were presented, and in the first-line setting with R-CHOP. This presentation by my colleague, Dr. Falke, was presented at ASCO and EHA, and saw on 30 patients an overall response rate of 100%, and a complete metabolic response rate of 77%. I think during the ASH meetings, there were similar results presented with glofitamab, again, an overall response rate over 95%, and a complete metabolic response rate still in this range of 70 to 80%. So I think it's a little bit early to say. It's manageable, this combination. Whether really we can reach to bring more patients in complete response with this combination early on remains to be determined. But with both drugs, randomized studies are starting or will start very soon, exploring R-CHOP versus R-CHOP plus a bispecific. Maybe we should attempt to use these drugs in more difficult to treat patients, and that's a discussion for the design of this trial. But again, the combination is feasible with classical chemotherapy, is feasible with lenalidomide, maybe not so attractive for DLBCL, and it's a possibility to combine with polatuzumab. And as I mentioned, mosunetuzumab continue to be developed in combination with polatuzumab for patients with relapsed DLBCL or patients not eligible for chemotherapy. I think we discussed tafasitamab, lenalidomide, we discussed loncastuximab, pola, BR. I think blinatumomab, which was the first drug developed, the first bispecific developed in lymphoid malignancies and approved in ALL, will have no hard time to find a space in the DLBCL field because of the continuous infusion regimen, but I know they are developing other ways to administer the drug. I think what we see on the bottom, besides selinexor we developed, is venetoclax, and maybe we haven't discussed BTK inhibitors and other targeted agents. We have BTK degrader, we have other degraders that are coming, we have the new IMiDs. So I think we should keep in mind that there are other targeted agents that are in development, and maybe some of them may be useful. Maybe we'll develop new combinations. The combination of ibrutinib, lenalidomide, and rituximab was found to be useful in some patients, and I think we still manage a few patients with these targeted agents. Venetoclax as a single agent, probably not, but in combination with others. And finally, at the bottom of these slides are immune checkpoint, which really have not shown benefit in patients with DLBCL, CD47 with early encouraging result, but now focused development on myeloid disorders and probably challenged by the development of bispecifics. But we'll see other antibodies, new bispecific targeting CD19, probably trispecific antibodies, and combination of these drugs. So I think we have really a field that is changing. And as we said, the discussion we had regarding the sequencing of this drug will not have been taking place 5-6 years ago when we had only chemo regimen in the relapse setting.